Okay.
I see all three of us.
Right, that's what I see too.
Okay. Just wanted to get that broadcasting on YouTube for viewers.
Looks good.
Thank you everyone for joining us for another Michael Davis e-lecture. This is the last lecture of the spring 2020 season, but we will be back in autumn 2020 with more lectures, hopefully online and hopefully in person. We appreciate everyone who has come and viewed our series this spring. I'm Keith Brown, the Administrative Director for the Center for Health Administration Studies. CHAS is a health policy and services research center that has been developing and disseminating health policy research for over 70 years. As you know, the global pandemic has changed the way we live and work, and thus we have switched to a virtual format for this lecture series, which we've received a great response from. Thank you very much. After my remarks, Professor Jean Marsh will introduce today's speaker, Chair of the Department of Public Health Sciences and Lewis Block Professor, Diane Lauderdale. To allow continuity, Diane will present her slides and then we will follow with a Q&A session. Please enter any questions you have into that Q&A throughout the lecture, and we hopefully will get to your questions. The chat feature has been disabled. Today's PowerPoint slides will be featured on the CHAS webpage, which is chas.uchicago.edu. And a recording of this presentation will be hosted on the CHAS YouTube page, which is searchable by UChicago CHAS. Professor Marsh, would you like to introduce Diane?
Thank you, Keith. It's a great pleasure for me to introduce Diane Lauderdale, a colleague in the Department of Public Health Sciences at the University of Chicago, and a good friend of the Center for Health Administration Studies. Diane does super interesting work that includes work on the health of immigrants to the United States. One of her most interesting findings was that she demonstrated Arab American women who gave birth in the months following 9/11, which was a period, as you know, of unprecedented violence and discrimination to this group, had worse birth outcomes than similar women giving birth a year earlier. And this was a difference that was not found in other racial and ethnic groups. Today, however, she is talking about her work on sleep as a behavioral risk factor. This work includes studies of how people's perceptions of sleep duration and disruption are related to objective sleep measures, as well as studies of how social factors such as social connectedness and loneliness relate to sleep, and studies of how both sleep perceptions and objective measures are associated with health outcomes. As a big fan, a virtually addict to my own sleep app, I'm very eager to hear how Diane, hear her talk about this research on the topic of population research on sleep quality and social determinants. Thank you so much for joining us, Diane.
Thank you, Jean and Keith. So as described, I'm going to be talking about my sleep research. There we go. And my outline today, I'm going to start by putting sleep research in the context of epidemiology and perhaps reminding people of what epidemiology is broadly, because our current moment has really, I think, given us a new and slightly distorted lens on the entire field. I have never before heard the word epidemiology so much, and so many people who have described themselves as epidemiologists. So it's nice to be in a popular field for once. Then I'm going to talk about measuring sleep and the concordance of survey and objective sleep measures, and then focus on work on social correlates of population variation in sleep, sociodemographic factors, and also with a little bit of attention to our current moment, the work that we're working on now on loneliness and social disconnectedness and sleep. So a little history of epidemiology. Even though the word sounds like epidemics, really the field of epidemiology, as it's been for the last 70 years, is about the distribution and determinants of all kinds of health and disease states in the population. Before World War II, the field really did focus on infectious diseases and epidemics, and the interventions were largely hygienic ones around quality of housing and water quality, as well as a lot of real lab-based work trying to understand the etiologic factors for infectious diseases. At the end of World War II, there was a moment, and the moment lasted until about 1982, when epidemiologists and the world of health research thought that infectious diseases were going to be conquered, were being conquered. Antibiotics had really changed treatment options, and tuberculosis was way down. The polio vaccine, the success of the smallpox elimination vaccine campaign, all contributed to this tremendous optimism that this, what's called the epidemiologic transition, when the primary causes of death in the population switch from infectious to non-infectious diseases, changed the field. And so starting around in the late 40s, epidemiology largely focused on non-communicable diseases and risk factor epidemiology. And this sort of a marker for this is the beginning of the Framingham Heart Study in 1948. And for the first, I'd say 15 years or so of that period, studies in epidemiology investigated clinical and biological risk factors for non-communicable diseases, primarily cardiovascular disease and cancers. So these are factors like lipids, blood pressure, weight, and then moved increasingly into behavioral and social factors starting with smoking, but really blossoming in the 80s, 90s, and into the new century. So these are factors like, as I said, smoking, socioeconomic status, alcohol consumption. However, this sunny story was interrupted with the beginning of the AIDS epidemic in the 80s, and there's of course been increased attention, which is extremely visible right now, on the epidemiology of communicable diseases again, although it now is informed by this sort of new sophistication and lens in the field of behavioral and social factors and how those interact with the etiologic agents for communicable diseases. So where does sleep come in? There are two really important cohort studies in epidemiology, which mark the beginning of epidemiologists noticing sleep, which they really did not notice until the 1960s. The most important of these is the Alameda County Human Population Laboratory Survey. Alameda County is where Oakland is, and this was a study which was put together by researchers largely based at Berkeley. And it was a large population sample of the diverse population in Alameda County, which at that time was more working class than Oakland has become more recently. And their first findings that got enormous publicity came out in 1973, and they identified that there were actual individual personal health behavior factors that predicted mortality. And perhaps with tongue in cheek, they labeled them the Alameda 7, because this is 1973 and it's following shortly on the Chicago 7 and the Harrisburg 7. But what these 7 factors were excessive alcohol consumption, smoking, obesity, sleeping less than or more than 7 to 8 hours, and that's where sleep enters in, physical inactivity, snacks, and not eating breakfast. And that not eating breakfast was the one that I would say caught a lot of popular attention, because it sounds like a bizarre and magical effect that this is going to help you live longer. In fact, it's because of this breakfast part that I actually remember reading the popular press treatment of this finding, which was my freshman year of college, when I never woke up in time to eat breakfast. So it really stuck in my head when the Alameda 7 came out. The other cohort that had looked at sleep hours is the American Cancer Society cohort. So this is actually an earlier study, but the findings, the important findings, mostly came out later than the Alameda County ones. And this is a very, it was a creative cohort establishment following on, the Framingham study, this meticulous study of about 5,000 adults in Framingham, Massachusetts, which brought people in for clinical exams every 2 years, was super expensive and was in one geographic area because they had to bring people into a clinic. Also, it was way too small to study cancers because cancers are a much rarer outcome than cardiovascular disease. So the American Cancer Society had this brilliant idea that they would get all their volunteers to enroll their friends and family, and they would practically for free set up a cohort of 1 million people. It was just, a paper and pencil cohort. They obviously were not bringing 1 million people in anywhere. And for reasons that are not clear to me, they asked people how much sleep they usually got at night at baseline in 1959-60. And they subsequently went on to report in a publication that is not much cited in 1964 among a boatload of different behavioral factors. But then there was a study in 1979, which is that third reference that got more attention, but is later. What they found was that there was a bizarre U-shaped association between sleep hours and subsequent risk of mortality. And so this is similar to what the Alameda County study had found, except that Alameda had grouped both the short and the long sleepers together as having non-normative sleep. And in this one, they actually looked at the hours of sleep. And this is what the 1979 study looked like, which was that both the short sleepers, so here we have people at both the left and the right, there are the men at the left and the women at the right. The people who are reporting that they usually sleep 4, 5, 6 hours a night have higher percent dead after 6 years, as do people reporting 9 and 10 hours than those 7 and 8 hour people. The really marked U-shapes at the top are the oldest group, who are 70 and older, and it gets flatter and really kind of a non-pattern for women with younger women, but you still see a bit of the U for the younger men. So this U-shaped pattern, this finding, this was a bizarre finding though, because nobody had any clue why you would see this, why there was a mechanism here. And so it did not have much impact on epidemiology, and people did not ask that often about sleep or study sleep because there was no mechanism to explain why sleep would be related to mortality. The mechanism that really changed the field in epidemiology is a landmark study, which was actually done at the University of Chicago. This sleep debt study, which was published in Lancet in 1999 by Ev von Cotter and her colleagues. And it's a laboratory study. It's not an epidemiologic study. It's an experiment where people are assigned to an experimental condition. 11 men, young men, were kept in a sleep lab for over 2 weeks. They could spend 8 hours a night in the bed for the first 3 nights. And then for 6 nights in a row, they were only allowed to be in bed for 4 hours a night. And then they had a recovery period of, they could be in bed 12 hours a night for the next 6 nights. And they were intensively monitored for the last day in each condition, although they were not allowed to sleep during the non-sleep hours. And what they found in that last day of the 4-hour 6 nights was that there were all kinds of cardiometabolic dysregulations. The glucose metabolism looked like they were becoming diabetic. Their cortisol levels were, the diurnal pattern was deranged. Their immune response was lower, and these hormones that are thought to regulate hunger, leptin and ghrelin, made it look like people were hungrier than they ought to otherwise look. And so with really fully realizing the potential implications of this, the paper concluded that voluntary sleep curtailment has become common. And this was this idea that everybody was sleeping less than they used to, irrespective of the underlying mechanisms when compared with the sleep recovery condition, sleep debt, so that's that short sleep period. which they said was experienced by a substantial proportion of people in more developed countries, is clearly associated with metabolic and endocrine alterations. So the idea here was that people in general in sort of 24/7 busy societies and wealthy countries were voluntarily sleeping much less than they needed, and that it was going to put them on a path towards obesity, diabetes, and other serious health problems. So suddenly there was a mechanism. However, note, this is not really consistent with that previous story because there's no mechanism for people who have long sleep hours to have worse health outcomes. This is a mechanism just for the short sleep hours. Nonetheless, this paper has been cited over 3,000 times in almost every epidemiologic study, which subsequently looked at sleep, and a host of outcomes cites this because this still remains the most compelling piece of evidence here. So when I got involved in sleep research, and Evan Cotter was the person who brought me into it, I had a couple of reactions to this literature. And I'm going to be spending most of the rest of the time here talking about my research to try to answer these two fundamental questions about this literature. Now, epidemiologists are taught to always be skeptical of findings and to first try to consider, are there alternate explanations for what the data are showing? And the two questions I had were, first, how accurate are self-reported sleep duration, as the mortality studies have found? Is this just, intuitively we know this can't be terribly accurate, but is it just a noisy measure with errors distributed sort of as if randomly around some true value for a person? Or is it a systematically biased measure? And then the second question is, could there be social confounders of the sleep and death association? And what that would mean is that there were social correlates of sleep variation that were not really recognized in these studies. Now, in truth, there's a third question I also followed up on, but I'm not presenting today, which is that issue of whether people in developed countries really were sleeping less than they used to, but we will table that for now. So how has sleep been measured in different studies? It's actually hard to measure sleep. So most of the epidemiologic studies until about 2000 used survey questions. And the most common is a really simple-minded kind of question, which is basically, how much do you sleep at night? It's also possible in a survey to ask people when they usually go to sleep and when they usually wake up. And I'll talk about why I think that's actually a better question. There have also been questions about sleep quality, sleep satisfaction, insomnia symptoms. So generally these sleep quality questions. Another way that you can collect sleep data is to ask people to record when they fall asleep and when they wake up each morning in a sleep log. And this is often what sleep medicine doctors or psychiatrists have asked people to do when they're trying to understand people's sleep. There are two objective measures. There's one I'm not going to talk about anymore besides now, which is polysomnography. So this is measuring sleep through brain activity. It requires a lot of different monitors on the body. It's what's done in a sleep lab or in a sleep clinic. The issue for the kind of research I do is that this act of having all these electrodes put on your head and all over your body is likely to actually disrupt your normal routine. And I'm interested in people's normal routine and variation in sleep, so it's not actually a good way to measure it. The last way, which is the one that's had an impact on population research, is to estimate sleep by arm motion. And when I started doing sleep research, this was a really novel idea. It's called actigraphy in the field. It's no longer such a novel idea because it's basically the research equivalent of an Apple Watch or a Fitbit or any number of consumer devices. So, okay. So why are survey questions so challenging? This question of how much do you usually sleep at night, it sounds simple. It sounds, if you're familiar with Kahneman's System 1 and System 2 thinking, it sounds like a System 1 question. It's something you should be able to just snap back and answer with that's intuitive and simple. In fact, it's very much a System 2 question that causes you to need to go through a deliberative and logical process. And that's because you need to realize that in order to, it's not a number that we have in our heads, unless of course you've been using an Apple Watch or something and been tracking your sleep over time, but that's actually not most people. You have to go through the process of figuring out across a behavior that's quite variable day to day for many people, when you usually fall asleep and when you usually wake up. And then you need to subtract in your head around midnight, which is a difficult cognitive task. And a lot of people faced with a survey question, they actually don't go to the trouble of doing this. And we've done some cognitive testing around the question. So, I mean, I think it's better to just ask people when they usually go to bed and when they usually wake up, not take up, wake up. And leave that subtraction around midnight and the idea that you actually have to go through this process to the interviewer. So I think that's a better way of getting this data, but it's still not ideal. And so the question is, what are you actually getting when you ask people this question? And for many people who either don't or can't go through this process and figure out what the answer actually is, an accurate answer, what you're going to get back is a socially desirable or a normative answer, or just anything to get onto another question that's easier to answer if they're taking a survey. And I just want to spend a moment telling you that this question of what's the socially desirable answer is not a new question in sleep, and that the answer that 8 hours is the right answer is not something that's a product of the early 20th century. It goes back at least to Maimonides here. And this is in his theological writing, not, I mean, he was a doctor. It's not in his medical writing. It's the theology and the idea that to have a life in balance, you're spending 1/3 of your time sleeping. So that's been around a long time, that 8 is the right answer. On the other hand, and I think this pretty much comes in with the Industrial Revolution, there's this other attitude that sleep is a little bit self-indulgent and lazy, and you're not accomplishing anything during your sleep. So you should sleep as little as you can to lead an effective life. And this is very beautifully said by John Wesley in the early 18th century, who wrote some very thoughtful sermons around sleep. He was the founder of Methodism. What is it to redeem the time from sleep? It is in general to take that measure of sleep every night, which nature requires, and no more. That measure which is most conducive to the health and vigor, both of the body and mind. So just to make the point that this ambiguity goes way back about what the right answer is. Now I'm just going to spend a moment telling you about objective measures, this the fitness tracker model. So these are research grade activity trackers. Some of them actually do tell you the time on the front. Other models do not. These are a couple of different models. There are quite a few now. The advantage that they have over a consumer fitness tracker, though, is that they give the researcher access to raw data, and they don't give the wearer any feedback, which frankly is an intervention in itself, which you don't want in the course of trying to figure out somebody's routine behavior. So the reason, there are people who are using fitness trackers for research. The problem is that they don't give you the raw data, and all you can get are the summary metrics that the manufacturer provides. And they're trying to improve those. I'm giving them the benefit of the doubt here. They keep trying to improve them, but they don't tell you when they change the algorithm they're using. So you can be in the middle of the study and suddenly, why is it that after May 15th, everyone's sleeping a little better or worse? And you just don't know what happened. I mean, and it could be that the algorithm changed. Anyway, they record the number of count of activity motions and the intensity of the movements per epoch, which could be 15 seconds, could be a minute. And the pattern of those epochs are used, the pattern of activity counts over the epochs are used to estimate sleep. And I'll show you in a minute what that looks like. And what you get are sort of the total amount of sleep time each night. You get various measures of how consolidated that sleep is or how much motion there is during that time. And you also actually get the times, the circadian timing of when people are asleep and when they're not. So there's a lot of information there. There's no first night effect. So if you do it for many nights, and you want to do it for many nights because people's sleep is variable, it doesn't seem to change how people sleep like the polysomnography, because their first night is on average no different. Research has found that for people who are hooked up to polysomnography and also wearing an actigraph, for healthy people at least, the correlation for duration is 0.8 to 0.9. But honestly, there's no way to actually validate this, because I can't believe that people move in the same way they usually do when they're hooked up to all those electrodes. So I don't know what this validation is really telling you. So there's no perfect way here. Here's an example of what an actigraph looks like. This was a bit of a joke to call it typical. This is the best sleeping person I've ever seen in a study I've collected. There's a little event marker, that little diamond at the beginning and end of the blue period each night. People were asked to press when they fall asleep, when they start trying to fall asleep, and when they wake up. What you're seeing here are the series of black lines, which indicate how many counts there are in each epoch. The yellow line is tracking the light. This unit also had a light meter. And the blue area is the inferred sleep period. You can see people are not completely still during their sleep, but this is a great sleeper. This is a really, they go to sleep and wake up the same time every night. They sleep pretty well. They're not like getting out of bed at any point during the night. They just move around a little bit. For contrast, this is like the worst sleeper I've ever seen. And it's really hard to figure out when and if this person is ever sleeping, although they're pushing that little event marker. You can see at pretty regular times still, but their sleep is not good and it's highly disrupted. So there's some subjectivity in even figuring out what to estimate here, especially if people forget the event marker. So it's not simple. So how similar are the survey answers and the actigraph durations? And here I'm going to give a little bit of findings from the first study I did where we added actigraphy. This was an ancillary study to a big cardiovascular cohort that was actually being collected out of Northwestern, the Cardia study. So it was an exciting University of Chicago Northwestern collaboration about 15 years ago. And what we found is that the correlation in sleep duration between people's responses to a survey question and to their actigraphy sleep duration was 0.47. So it was a moderate correlation, not a high correlation. Self-reported sleep averaged 48 minutes longer, which is not that surprising because people tend not to subtract. Even if they're really accurate about when they fall asleep and wake up, they're not subtracting all the little bits of time that they're awake during the night. And people in middle age and older ages are awake little bits of time all through the night. But here's what we found that was so revolutionary in the field, which is that people with risk factors for mortality, including fair or poor self-rated health, who are obese or who reported more depressive symptoms and some other things too, they systematically reported shorter sleep at the same level of measured sleep. And what that implies is that this reporting bias could in itself generate associations between shorter self-reported survey sleep and poor health outcomes, even if there's no association with an objective measure of sleep. So this question of could there be a systematic bias that was inflating or even creating these associations with health? Yes, it was possible. So that's that first question. Now for the second question, I have some information from, again, the Cardia study, and then most of the time I'm going to be presenting information from the data collection I'm involved in now. So the Cardia study had the kinds of socioeconomic data that are typically collected in epidemiologic studies. And I'm going to show you now how the sleep categories from actigraphy fell out according to education groups, and then I'm going to show you race, sex groups. So the Cardia, so when we my career, I really remember when we first looked at these data. And the reason was because I had this mindset, which was really influenced by that research that it was people, working 60, 80 hours a week in wealthy countries. So it was the professionals and your hedge fund managers or whatever who were willfully sleeping less than they needed because of their busy, productive lives. And that was not what we found. So here we have categories. So the yellow bars are people whose actigraphy sleep was less than 4 hours a night over an average of 3 nights. And then the orange is 4.5 to 6. The red is 6 to 7.5. And 7.5 and over was black. So in this middle-aged population in their 40s, sort of prime work years, there weren't that many people who truly had more than 7.5 hours of measured sleep, although there were some. They were spending more than that in bed, but you don't sleep all the time you're in bed. So what you see here, and first, a couple things to notice. The college and post-college look almost identical. So that was a little distinction that didn't matter so much. Basically, the people with less than a high school education are much more likely to be in the short sleep categories than the people with college degrees. And it was, if you look at that short sleep area, the short sleep yellow bar, you see a monotonic association with fewer people in that really short sleep category with more education. And conversely, you see an increase in the red and the black bars, the longer sleep areas. So it was not the people who had the fancy jobs who were sleeping less. It was people who were in, who had fewer advantages. So sleep was like a good that they were not getting. And then the Cardia study was started in the 1980s. And in the 1980s, in an effort to increase diversity of populations being studied, NIH really pushed for people to look at both Black or African-American populations and white populations. And so even though this study is still being, there's still very interesting findings and follow-up decades later, that is baked into the study, that it was by design half Black and half white. Just sort of incidentally, later cohorts started by NIH, you see an expanding definition of what diversity is, so that the cohort started in the 90s, you see Hispanic populations, and after 2000, you start to see Asian populations. However, we are in the 1980s here, even though the data were collected in the 2000s. And what you see was really also, in addition to the education, the race gradient was a shocking finding at the time. So we have white women, white men, Black women, and Black men. So first of all, women sleep more than men. So that's true within both race groups. But the big finding was the difference between the white and the Black race groups. And this difference was so great that the average sleep difference between the white women and the Black men was 1.5 hours. So it was just an extraordinary finding, and with the education, and there were also income gradients, really underscored the fact that the people who were not sleeping well were not the people with the high-powered jobs. It was people who had much more difficult lives than that. So now I'm going to turn to the current data collection that we've been working on. So the National Social Life, Health, and Aging Project is a University of Chicago and Newark-based cohort study. It's a national probability sample of adults born 1920 to 47, subsequently enriched with the baby boomer cohort. It includes in-home interviews and biomeasures. And at this point, the alert listener will say, this is a cohort study. It's a national cohort study with in-home interviews. This is almost unheard of. And it was possible because Newark has a national field operation. There are no, epidemiologic studies are almost always in a geographically constrained area so that you can actually, if you're taking any actual in-person data from people. So it's an extraordinary study. It was designed primarily by people in sociology, statistics, medicine, psychology, and a bit of epidemiology after the first round of data collection at the University of Chicago. It's particularly rich in measures of social interactions, reflecting the expertise of our sociology department. So this is a list of current investigators. There are lots of people from the University of Chicago or who used to be here in the project. Linda Wade is the PI. And the sleep was not part of the base study. I had the opportunity, in working primarily with Phil Shum, but also Martha McClintock and others, we added sleep measurement in the second wave, which was in 2010 and 11. 1/3 of the wave 2 participants were randomly selected and asked to participate in the sub-study. The sub-study included 3 nights of actigraphy and a sleep booklet with some additional questions and a 3-night sleep log, which were the same 3 nights as the actigraphy. And here's a flow chart. Basically, what we end up with is about 750 people. It's a little complicated. I'm not going to go into some of the reasons why there's a little bit of dropout. The base study is a bit over 3,000 in wave 2. But again, it's a 1/3 sample, and there's some, not perfect participation or perfect data collection. So the survey sleep questions, I intentionally set this up so that we had different measures of sleep duration, because I was really interested in these issues about the difference between people's perceptions and the measured sleep durations, and how each of them were related to both the upstream social and demographic factors and the downstream health factors. So at this point in wave 2, my previous work about how hard the single question about sleep is to answer caused me to push with success to have sleep time collected in a different way in the core of NSHAP, which was to just ask people their usual bedtimes and wake times, so that we got, we avoided some of the issues with the self-report. And it was asked for weekdays and non-weekdays, and then a 2/7, they were weighted for weekdays and work and weekends. It turned out this is an older population, in their 60s and older. There actually is very little difference between the work days and the weekends, which is different from what you see in a middle-aged or younger population. There's a standard question about feeling rested in the morning that was part of the depression screener. And then in the sleep booklet, we also asked, and they were getting this at a few weeks separated, so we were not inducing consistency by asking in a different way. We just asked the simple single question, how many hours do you usually sleep at night? And we asked insomnia symptoms, how often do you have trouble falling asleep, staying asleep, waking up too early in the morning? And we had the 3 nights of sleep log. Now those 3 insomnia symptoms coupled with that question about feeling rested in the morning is basically the insomnia symptom score that have been included in a number of different studies over the years. So this is an estimate of insomnia. Each one has a frequency attached to it. For duration, consequently, we have 4 different measures of sleep duration. We have the single question, how many hours do you usually sleep at night? We have a calculated sleep time from asking people when they usually go to bed and start trying to fall asleep and when they usually wake up. We have the sleep log time from 3 nights of the sleep log. And then we have the actigraph's total sleep time from the same 3 nights. And below we have just a simple Pearson correlation matrix for these 4 measures. And what should jump out at you is that none of them are all that high. In particular, the single question to actigraphy correlation is only 0.29. The sleep log, our best correlation is between the sleep log bedtimes and wake times and the more generic usual bedtimes and wake times, which is 0.56. So these are not, they're very real significant correlations, but they're not high ones. I should also say part of the reason that I like the asking people about bedtimes and wake times and not usual sleep hours is because for most people, there are no normative answers to that. There's just sort of no pull that it sounds better to say 10 than 11 or 11 than 12. So I think that it's a better survey question in that way. So we've done a great many studies with these data, but what I'm going to concentrate on today, and this is partly because of the moment we're living in, is the associations between loneliness and social isolation with these various sleep measures. This is a paper that currently is in the revise and resubmit phase, and so things could change a little bit, but I'm going to present sort of the core data. I have a wonderful group of co-authors on this paper. Jade Benson is a terrific 4th-year college student at the University of Chicago. Aloysia McSorley is a doctoral student in public health sciences, and Louise Hockley at NORC is a foremost authority on loneliness with a psychology background. So loneliness and social isolation, in some of the literature, these terms are used interchangeably, but they mean different things. Loneliness, which really comes out of a psychology literature, refers to the distressing feeling that a person's desired social needs are not being met. Social isolation, which really comes more from a sociology literature, it summarizes what are in theory observable social connections. So loneliness and social isolation are therefore distinct, and they generally just have a low correlation. So prior literature, I'm not going to go into much detail here on social isolation, loneliness, and sleep. Loneliness and social isolation predict increased risk for morbidity and mortality there's a vast literature on that. Now, for sleep specifically, there are not that many studies. They've both been found to be linked to worse sleep quality specifically, but almost all of these studies have used self-reported sleep measures. And I want to highlight one study which Louise and I and some others worked on a few years ago. We measured loneliness in the Hutterites. So this is Carol Ober, is the PI of this project. The Hutterites live a communal farm life in northwestern US and in Alberta, Canada, and areas. They have all their meals together. It's completely communal. So they are not socially isolated. They are all around people all the time. And yet they do report varying levels of loneliness. And we found in that population, a small pilot study really, where we used actigraphy, that their expressed loneliness was associated with sleep disruption from the actigraphy, which we measured there with the metric called fragmentation, but the metrics are all correlated for this sleep disruption with actigraphy. So it was really an interesting finding to show that loneliness separate from the depth of the number of social interactions was related to sleep. In this study, the social isolation measure is really rich, again, showing the sort of the contributions of sociology to NCHAP. There are 4 measures of the social network, including the network size, range, proportion living in the same household, and frequency of interactions. There are measures of social participation, group meetings, socializing with friends and relatives, volunteering, religious service, number of friends. And in this case, each of these variables was standardized, averaged, and then standardized. And that would have given a measure of social connectedness. We take the inverse because we wanted to go in the same direction as loneliness. So it's a social isolation rather than connectedness metric. So again, it's a standardized metric with a lot of things going into it. Loneliness is the 3-item version of the UCLA loneliness scale, which is widely used standard in the field. And it doesn't use the word loneliness though. It asks people the frequency of their feeling that they lack companionship, they feel left out, they feel isolated. Scores range, our scores range from 0 to 6, and the correlation between the loneliness and the social isolation in this study population of older adults is low but highly significant. It was 0.2. So our research questions are loneliness and social isolation both and similarly associated with sleep quality, by which I mean both, insomnia disruption as well as sleep duration. And do these associations differ depending on how we are measuring sleep? So just a tiny bit about the NCHAP sample. The average age at this time was 72.5 years. It's just a little over half female. It's the modal education category is some college with 35%. It's the race ethnicity distribution is very similar to what is the actual population distribution of older Americans. And about 70% are married or living with a partner. Our actigraphy measures, we're going to focus on 2 of the measures of disruption. The number of minutes awake during the night, which is called wake after sleep onset, or WASO, as it's known in sleep world. The percent sleep, which is the proportion of that sleep interval between when people fall asleep and wake up that they're actually sleeping. They're pretty highly correlated. 4 duration measures as previously described: the actigraph, sleep duration, the single question, the sleep log calculated duration, and the calculated time in bed from those core questions about usual bedtime and wake time, and then an insomnia symptom score, as I've described, that goes from 0 to 8 with having trouble falling asleep, staying asleep, waking up too early, or feeling unrested in the morning. So here, just to give you a sense of what those sleep measures look like, the average sleep duration from actigraphy is 7.2 hours. The number of minutes awake during that is on average 40 minutes. And the average percent of the sleep interval spent sleeping is 91.5%. The self-reported sleep measures, the insomnia symptom score, which can take values from 0 to 8, the average is 2.8. The single duration question, the average is 7.4 hours. And both the bedtime to wake time, whether from the sleep log or the calculated or the usual sleep bedtime and wake time questions in the core questionnaire, average a bit longer a bit over 8 hours. So our analysis, each sleep measure was modeled as the outcome, so 7 sleep measures in separate models. We use ordinal logistic regression from the insomnia symptom score, but OLS for all the others, which are continuous measures. 2 models are run for each of the 7 sleep outcomes, one where social isolation is the predictor, controlling for demographics, and one where loneliness is the predictor, controlling for demographics. And then we are taking into account this as a complex survey with, PSUs and weights. So here are the findings for social isolation. So what you're seeing are beta coefficients, except for the odds ratio for the insomnia symptom score from the ordinal logistic, and 95% confidence intervals and p-values. These just have the sociodemographic controls in them. So WASO and percent sleep are both strongly related to social isolation. So people who are more, a standard deviation greater isolation score is associated with 0.13 hours more WASO and negative 0.11% sleep. That was probably minutes for WASO. There's no association with actigraph total sleep time. For the self-report measures, we have no association with the single question duration or insomnia, but we have an association of greater isolation is related to longer sleep interval, whether from the sleep log or the bedtime and wake time questions. And on further analyses, we found that this was the wake time. So people who are more socially isolated wake up later in the morning. They don't go to bed earlier at night. For loneliness, we have similar associations for WASO and percent sleep. So people who feel more lonely have worse sleep quality with actigraphy. Still no association with actigraph total sleep time, but they have the opposite patterns for the self-report measures. They report on average shorter sleep duration from the single question, although not from either of the interval questions. And they have a very strong relationship with insomnia. For each additional point on this loneliness scale, which went from 0 to 6, they have an odds ratio of 1.31, highly significant, more insomnia symptoms. So we are trying to figure out what to do with further confounding. We've focused on 4 health states, which are quite important in older ages and either have been found or are logically related to sleep, and as well as the outcome, social isolation and loneliness. They are cognitive impairment, frailty, pain, and obesity. The problem here is it's really unclear whether it's appropriate to think of them as confounders, and we're wrestling with this. So we're measuring sleep, social isolation, and loneliness, and these conditions all at the same time. To be frank, every single one of them has the possibility of bidirectional associations. So it's a little hard to know whether we're looking at confounding or potentially mediation, which is the one in the middle in these bidirectional associations. So I'm not going to present these findings, but simply to say that there are, for some of those 14 models I've just presented, one or more of these do seem to confound the associations, and are likely involved in the associations we're seeing. But it gets too complicated to present it all right here. So to summarize, loneliness and social isolation are both related to worse actigraph sleep quality, and neither are related to actigraph duration. Loneliness is related to self-reported sleep duration and insomnia symptoms. So these are perceptions of how people sleep, neither of which link up very much with actigraph measures of duration or continuity. And I haven't shown you the insomnia actigraph continuity, but they're not so closely related either. Social isolation is related to longer duration from bedtimes and wake times, and it has to do with later wake times. So there are a number of associations, and for the actigraphy, they look the same, and for self-report, they look quite different for these 2 measures. So the implications here are that dissatisfaction with sleep So the short self-reported sleep insomnia symptoms really is strongly associated with loneliness, but it's not associated with the actual lack of the social connections. It's this sort of dissatisfaction with one's social needs being filled. Both loneliness and social isolation are related to more disrupted sleep. Whether it's causal or not, we don't know, or even what the direction here is. It could be going the other way. But I want to note, I'm not showing you this, in numerous studies that we have done or are doing between our sleep measures and health outcomes, it is these sleep disruption measures from actigraphy, the wake after sleep onset, sleep percent, fragmentation, that are predictive of poor health, including cognitive decline, poor olfaction, worse cortisol profile. And so the fact that they're both social isolation and loneliness are associated with more disrupted sleep is potentially meaningful. And if that direction goes from them to sleep, as opposed to the other direction, our social isolation could have health consequences through this mechanism. So those are the slides I have, and I have some time for questions.
Great. Thank you, Diane, for a very impactful and fascinating presentation. We have several questions, and I have my own, but I would like Jean maybe to provide her thoughts on any questions that she has at the top of the Q&A portion.
Sure, I would love to, but I guess I'd rather start with a couple questions from the audience that I share. And one of the ones I share comes from Dave Ennis, who asks whether daytime naps are counted in the measures, and power naps apparently, from my reading of the literature, are healthful, are conducive to health. I mean, how do naps figure into this research?
It's a good question, which a lot of people ask. So naps are hard to collect data on. We have self-reported naps in NSHAP. And what we found, at least at the older ages, is that naps are not compensatory for less sleep during the day. And in fact, people who sleep more at night also need to sleep more during the day. So it really is, and it's a bad predictor for subsequent outcomes. But this is maybe different than people in a younger age group for whom this power nap idea is that it's a compensatory mechanism. And it's difficult data to collect. People often sort of go through the motions of napping, but don't actually enter into sleep. And it's not clear whether that should count or not. It's pretty hard to figure out, again, with older adults from the actigraphy, when people are napping or not, because there can be a really still period for 10 minutes during the day. And is someone just being really still, or are they actually napping? We are trying to line up our self-report data with the naps, but it's actually a morass, I would say. But certainly at older ages, it's not a good naps. There is no power napping that we're seeing in this cohort.
That's very helpful. Let me run through a couple other questions before I turn to my own. Peter Fugel asks, how do sociodemographic correlates of sleep quality relate to job characteristics, such as unstable work schedules? These are probably things like airline pilots and residents and others who have such low-wage workers who have unstable schedules.
Yeah, there's a great deal of research about shift workers and unstable schedules and sleep that's largely in the circadian timing literature. People who have shift work tend to get less sleep. They're sleeping at a different time of day. It's not just that, they just don't get as much sleep, and there seem to be deleterious health consequences for shift work. My experience I did one study where we were looking at the American Time Use Survey as an indicator. So this has people's 24-hour time diaries collected by the Bureau of Labor Statistics. There were not as many shift workers using that as we thought there would be. So I am a bit confused by this literature. It's not my area of expertise. And I think we like have a couple of shift workers in NSHAP. It's just not, it's not in this age range again. I would say it can't be good. To really go out on a limb here. It's probably not ideal, but people who are younger, so when people get into their middle age, they have less capacity to adapt their circadian timing. So they're, it's why people as they are older, if they find themselves staying up very late one night, they're not able, like a teenager, to sleep 12 hours the next night to make up for it. You become less and less able to do with that. You just keep waking up at the same time. People who are closer to my age will recognize that this happens. It's why the weekdays and weekends don't look very different in NSHAP, frankly. So, a lot of the people who have shift work, if they're in a younger age group, by which I would say younger than mid-30s, they may be able to make up for the sleep that they are lacking, but it is likely to be more harmful at older ages.
Interesting. I mean, that the research on airline pilots who presumably live less long lives than people who don't have that kind of lifetime schedule of shift work. Do you know about that research? It's sort of vague to me, but does that make sense to you?
Yes, I'm trying to remember. I actually I have a problem set question I pulled in my course. I can't at the moment remember, but yes, it's not good.
Yeah. So Renee Moore asks, were the white and black sleep study subjects of comparable ages, as well as education and economic backgrounds? So was ethnicity the only difference?
Okay, so we're talking about the study of the middle-aged adults, the CARDIA study, which is a 4-site cardiovascular cohort started by the National Heart, Lung, and Blood Institute in the 1980s to look at the development of cardiovascular risk over time. They are the same ages. At enrollment in the mid-80s, they were 18 to 30. So the whites and blacks are very much the same age. The education and income outcomes are less different than they would be in a general population representative survey that was started, at age 40, like the measurement that I used. The modal income category, I recall, for the Black population was actually like $75,000 to $100,000 at that point. And it was actually a higher category for white people, by which I take it to mean that if you agree to be in a cohort study and manage to stay in it for 20 years, that is a terrifically good sign for who you are and your future well-being. So cohort studies are a great intervention if you stay in them. So I think that population became less and less representative over time, but there were education and income differences between the Black and the whites, but they were not enormous.
Oh, okay. And Kenneth Catalanit asks, have you looked at clinical depression correlation with sleep disruption as both are related to poor health outcomes?
Yeah, so depression, yes, it is. It is related. Depression is also strongly related to loneliness, so strongly it's hard to know how to even separate the measures, or if you can. You can't, it's like putting both education and income in a model. They just, you can't tell where one starts and the other ends because they're so tightly linked together. So yes, depression is a big predictor.
Right.
And it could confound all sorts of relationships or be on the causal pathway.
Okay. And Summerson Carr, hi Summerson, how should we make sense of the gender gap in sleep across demographic groups?
Yes, the gender gap is super interesting to me. So in study after study, in general, one finds that women sleep longer and they sleep better than men at pretty much every age group. However, women are less satisfied with their sleep. They sort of report more insomnia symptoms, even though objectively they have better sleep quality, and they report shorter sleep often. And I mean, I take from this that women actually have a greater sleep need than men. If we go back to sort of John Wesley time, there's an old English aphorism about sleep that it's 6 hours for a man, 7 hours for a woman, and 8 hours for a fool. And honestly, there does seem to be, on average, close to an hour difference often between men and women. And the fact that women are less satisfied with their sleep, I think either means that they need even more than what they're able to get in their schedules or what their physiology allows them to get, or that men are just in a sense, underreporting dissatisfaction because I know this is being recorded. They're a little oblivious about their health or don't want to. I pause here, but I will leave that to you. Whether it's a reporting issue or an actual physiologic issue is unclear and really hard to separate.
Okay, great. And two more. Luis Orta asks, do sleep aids, sedatives or hypnotics change any of the correlations?
You know, we're working on that. My experience, no. Sleep aids in themselves are not a great indicator. I mean, they can be a marker of worse subsequent health outcomes across multiple domains in some studies. It's not clear that it's actually a causative agent, or rather that there are, you know, some of the reasons why people feel they need sleep aids are in fact bad for health or bad health indicators. In general, you know, sleep physicians, and especially for the older adults, really try to avoid sleep medications because there are some potential downsides, unintended consequences of sleep medications for older adults. They often help people fall asleep quickly. They don't necessarily help with sleep continuity during the night. It's a complicated problem.
So we have a related question from Renee Moore about what about meditation, mindfulness, focused breathing, those non-medication life habits?
There are people who don't work on that. I mean, there are people doing intervention studies, absolutely. I mean, the intervention studies often are around factors like those or around physical activity. If you have not seen a giant headline in the science section of the New York Times reporting those results, I would say there have not been any strong conclusions yet on them, because everyone would be thrilled to read about that and to learn about it. But logically, of course, it seems like there should be an effect there. And I haven't looked systematically at the literature in that area.
Right. Okay. What about Byung Wang asked, does REM sleep have some sort of role in sleep research findings? If some people dream more, or in terms of mental health, sometimes people with high stress or trauma may have more distressing dreams and wake up more. I guess the question really is, what can you tell us about REM sleep?
Yeah, not too much. And that's because the research I've done has not used polysomnography. You need to have this measure of the brain activity and also motion in the face in order to figure out when REM sleep is, because it's a combination of complete stillness, no motion at all, with an activity pattern that almost looks like someone is awake in the brain. So it's that it looks different. This is how, you know, you get it at sleep, what's called sleep architecture, or the stages of sleep, including REM sleep with polysomnography. One of the limitations of using actigraphy to estimate sleep is that we do not get a measure of that. One could hypothesize that somebody who has very disrupted sleep with a lot of motion while they're sleeping is not getting much REM sleep, because you really are very still during REM sleep. It's a really interesting area. I don't have much to add on that. You need a different sleep researcher for that to answer that one.
Well, I think that's helpful. These questions are great and show how much interest there is in this topic. Now, from Harold Pollack, someone you know well, how does household composition, the presence of a companion, factor into these statistical relationships?
Well, we wrote a paper about that.
The two of you?
No,
Harold, did you forget about that paper?
No, Harold didn't write it. That's,
okay.
that was my team at NSHAP.
Okay.
So we looked at the married versus unmarried, many of whom are widowed and some of whom were never married and some are separated, divorced, in NSHAP. And we found that the married in general had better quality sleep than the unmarried. And most, but not all, shared a bed. We also had the question about that. We did find a little bit of evidence that people who had a better quality marital relationship also had better sleep, as opposed to a sort of negative quality marriage, which not that many people had. People were generally happy with their marriages in NSHAP. And again, the excellent attention to questions to get at marital quality, again, show the fact that our sociology department helped design this study and that Linda Waite's area is reflected of research in this. So people in general do sleep better when they have a companion. People who are speculating way beyond their data, but plausibly is that you do need to feel safe to fall asleep. And that if you feel you need to maintain vigilance because you don't know what's going to happen at night, whether it's just a perceived, concern that somebody might break into your house or, the sky's going to fall, that does interfere with sleep. And so we may, in terms of evolution, just be predisposed to sleep better when we're in a group, when there's someone else there for safety.
Great. And another question from Sid Ulavicius of SSA. Hi, Sid. He's very interested in the impact of the research on 90-minute sleep cycles. Is that something you can tell us about?
You need PSG for that one too. So in general, people have these 90-minute cycles where they go from deep sleep through REM sleep and light sleep. And then you're more likely as you get older to actually wake up in that light sleep era and maybe not be able to fall asleep again. And the length of those, the ideal 90-minute pattern also can get kind of distorted and change over the course of the night. It's not, again, because I don't do PSG research, it's not something I study. Okay,
thank you. We have a question from Jennifer Lee. These days, I think it's easy to experience more social isolation by distancing yourself from society. But is it good to sleep less or more because you don't use up much energy physically?
I think the answer to this may depend a bit on people's age. I'm not sure exactly where the question is in there. So what these data suggest, again, for older adults, is that having fewer social interactions is going to result in more disrupted sleep, if in fact it's a causal association. That's what those data I showed you suggest. I have not found in any of the research I've done in the older age group and in very little of it with the middle-aged people, that sleep duration itself is that important for health. It's really this sleep continuity that being able to sleep in the time you set aside for sleep that seems to be related to health. So I don't think people should worry at all. They should get as much sleep as they want to get in this. I'm not that kind of doctor. I shouldn't be giving advice, but sleep disruption, and people may be experiencing sleep disruption now for innumerable reasons, and they could have to do with less social stimulation, is not great, but if hopefully a few months is not going to change the course of anyone's health trajectory.
Great, thank you. And Kimberly Korolewski asked whether the negative effects of, say, sleep deprivation or sleep disruption can be ameliorated by change in these patterns or through intervention.
I'm not exactly sure what the...
I think maybe she's asking whether intervention studies show impact.
Impact with respect to the sleep itself?
Right, improve the sleep and the outcomes.
Oh, there's more work. The problem with sort of looking at an intervention that intervenes on sleep and then outcomes is you're limited to pretty short-term outcomes unless you're going to study people for a decade. So there's a great deal of interventional research about sleep itself, with sort of finding various effects in various populations. The really rich literature that finds an outcome is the psychology literature that's looking at cognitive processes, because there are immediate outcomes of poor sleep and short sleep, on worse memory and problem solving and ability to do those various kinds of tests, drawing between the figures and things. So there are really strong effects of sleep on that and of intervention studies.
So a couple more questions we have. I was curious about this also. When you were talking about the measurement and you talked about the need to subtract at midnight.
Oh,
well, I wasn't clear on what that's about.
That's like an executive function problem. So you say, how much sleep do you usually get at night? And the person thinks, I usually go to bed at 11:30 and I wake up at 6. And then in order to give you an answer, they need to figure out the difference between 11:30 and 6. And people are not that great at doing that. We are base 10 people, and this base 12 situation is really tough.
Okay, so got it.
Even among medical students, who are a bright lot, they screw it up. They don't always subtract right. It's just, it's not easy to do on the fly. Mental arithmetic is hard.
So that's very interesting. And are there differences in measures of loneliness and social isolation between white and Black populations?
Oh, so right. Then we need the population, the sample structure from cardio with the questions that are in NSHAP. The NSHAP, although there was an oversample of Blacks and Hispanic populations in NSHAP, the sample size is still not large enough in the sleep sub-study to really look at that. And I have not looked in the larger study. There is an answer to that, and I suspect it's been published. And if I weren't worried about, I would be looking on the side here to find it, but because of this whole webinar thing, I can you all, so I'm not going to. I suspect the answer is in there for the older population. I don't know it.
Okay, all right, great. Well, if people are really interested, they can get back to you on that. I think we've addressed most of these. Here, this is an interesting one we haven't addressed. This has to do with people who drop out of the study. Have you looked? This is from Natalie Gonzalez. Were there significant characteristics and similarities of individuals who dropped out and those who continued on, as you mentioned, in this cohort? For how many years was it? It was.
Oh, okay, that's the cardio one. But okay. I can answer this in general.
Okay.
So this we know, and we know it going back to Framingham. People who are easy to recruit into a study have better health. They have better psychological health, mental health. And people who are easy to maintain in the study are always better off, so that the study population becomes less and less representative unless you really try hard to keep the more difficult to maintain people in the cohort. But there is, yes, the people who agree to be in a study are always in better shape than the people who decline to be in a study, in every study.
And if they hang in there for how many years was that study?
20. Man, was that good for you? Yes. It was good for your income. It was good for your health.
All right, very good. We have one more question and then I'll turn it back to Keith. Dave Swanson is interested in whether there's been any sleep research with homeless populations.
That's a great idea. I don't know whether there has or not. I mean, usually in research, the answer is always, of course, there's been some. Yeah. I don't know it, but that's actually that is a great area to look into. That would be really interesting.
All right. Thank you. Keith, you want to take over?
Sure. You know, there was one more question that came offline, and it had to do with underlying causes of late onset sleep disorders. And I wanted to piggyback on that question and ask some of the determinants of health and risk factors involved. Can that be almost like a cycle that continues? For example, your risk factors increase for obesity, loneliness, depression, and as those increase, it impacts your sleep. Is there any way that you would recommend in your findings to help that kind of stop that cycle?
Right. Even understanding what the cycle, whether it is a cycle, is really, I mean, what it requires are repeated longitudinal measures or interventional studies, which you actually can't intervene in the ways that you might want to intervene in sleep, because you can only make people sleep worse. You can't really, it's hard to make it better. And these relationships, many of them are likely bidirectional. So, you know, the question that originally got me into sleep research, drawing on the Yvonne Cotter's work, was this issue of whether people who sleep less are more likely to gain weight. And what I have found, and it may just speak to the middle-aged population and not to children, for example, there may be something else going on, is that it really was not that sleeping less caused you to gain weight, but that people who weighed more didn't sleep as well, which is really not as exciting a finding. So before one is intervening on the cycle, you need to figure out, you need to really have good causal evidence, or you're not going to affect the cycle. And there are, you know, with much of the research we've done, like the fascinating paper where we found that sleep quality measures, again, the sleep disruption with actigraphy was related to a worse ability to identify smells, olfaction, which is a unique, not unique, but an interesting measure in NSHAP that Martha McClintock, I think, and Jay Pinto have worked the most on. And we just don't know whether that's really causal. I mean, it's even possible that people who have less stimulation from smelling things are sleeping worse, honestly, although it seems if it's causal, more likely it could be in the other direction. But even more likely, it seems like there's some underlying neurologic process which is causing both of them to worsen over time. So, you know, this whole cycle intervention is just, it's really, there's a lot to know that we don't know yet about sleep. It seems like it's important, but how it's important, not completely clear. We do have longitudinal evidence about sleep and declining cognitive function among older adults. That one I almost believe.
We do have a couple more questions coming in if you have time. Going back to gender differences with sleep, someone asks if womenopause or menopause affects insomnia.
Yeah, and actually there was a study that was designed in part to answer that, the study of women across the nation, the SWAN study, which was a big multi-center study that enrolled women in the years right before menopause and then followed them through and after menopause and collected actigraphy data and self-report. And I mean, there's evidence of increased insomnia reports. The effects on, and I haven't recently looked at where the literature is on this. There's less consistent evidence for any of the objective sleep measures, although clearly for some women it matters a lot. But I think there's a great deal of heterogeneity in the population on that one.
Another quick question. Someone was asking if pets were considered as companions in any of the studies, and is that correlated to sleep and loneliness?
Yes. I have two anecdotes on this before I'll try to answer. I'm not sure I have an answer to the question, but I have good anecdotes. So when that Hutterite paper came out, I had the next Saturday evening on in the background while I was reading. I had the TV on. It was quite a while ago. And on Saturday Night Live, Seth Meyers referred to this study, and he said, you know, did they that lonelier people had more disrupted sleep, and was this because of all the cats in the bed? But I think he missed out on the fact that he'd confused social isolation and loneliness like everyone does, and he had not taken in the Hutterite part. So it was irrelevant, but it was the only appearance of something I've worked on Saturday Night Live to my knowledge. The other is that, I mean, I am impressed with people asking some wonderful research questions here, because typically, and you may have screened them out, people tend to, when you give sleep research talks, even when you're talking about hundreds of people in population research and epidemiology, you get all these personal stories. And one of the funniest ones was giving a talk at the National Bureau of Economic Research at one of their meetings that was actually about the sleep trends over time part. So it really was not about individual effects at all. And this very distinguished economist sort of said, have you looked at cats? My cats keep waking me up during the night. So the pets, they can go either way. They clearly can interrupt your sleep, or they can give you a feeling of safety. And whether this is a cat versus dog thing is unclear. I have not looked at this, but I'm trying to think if we even have the data to do it. I mean, clearly it's of interest to some people, again, on this kind of personal self-help. When you do research on sleep, it sort of crosses over to sounding like self-help advice to people and not, you know, population health research. And I understand that. Sleep is really important to people.
Yes. Peter Fugile has another question. Is self-rated sleep quality associated with objective measures to a similar degree as self-related health?
Okay, so again, just in NSHAP, we took the answers to the insomnia questions and we looked at how they related to the actigraphy metrics that they seemed to reference. So people who said that they had trouble waking up in the middle of the night, not being able to fall asleep, did on average have somewhat more WASO, or the objective measure that it seemed to go together with. There were some other relationships though that were just kind of odd. Makes it hard to make that crosswalk. For instance, people who said that they had trouble with waking up too early and not being able to fall asleep again did on average wake up earlier. They also on average went to bed earlier and on average got more sleep than people that didn't endorse it, which makes you think differently about the answer to the question if in fact on average you're getting more sleep if you wake up early. And other relationships we thought just weren't there. So people who said that they were, you know, more tired in the morning, that had no relation to how much sleep they were getting. So it's really different. People's satisfaction experience of sleep is related to what you can objectively measure, but there are other things going on there, and whether they're sleep need or these other psychological factors, it's just really hard to know right now.
Yeah. I think this will be the last question. Someone was asking, going back to, you were talking about the differences with socioeconomic populations and vulnerable populations having less effective sleep. Someone is asking about less hectic societies or other countries, actually, outside of the US, what are your findings related to sleep with foreign countries and perhaps third world countries compared to the US?
Okay, so my entry to this is a little more historical than geographical. Part of that third question I said I wasn't talking about, which is whether people are sleeping less than they used to, is that the standard sleep textbook has had in it for many, many generations the statement that people sleep less basically since the electric light bulb. And so there have been a few people who took actigraphs and measured sleep in remote parts of the world that don't have electricity. And what they found is that people's average sleep duration is not very different from ours. They often spend longer in bed in a dark period, but it's more disrupted. So the average sleep is not that different. And I've always found this statement that people, the electric light bulb made a difference to be frankly absurd, because part of that is that, this idea that people used to sleep when the sun went down. Had these people ever been to Northern Europe? Did they really think that people in Sweden slept 2 hours a night or 1 hour a night in the summer and 22 hours in the winter? I mean, so there is a seasonal variation, but it's like at less than an hour in places that have extreme sleep, extreme sunlight differences over the year. So, the differences in self-reported, I have done some international comparisons, and the sleep durations are just not very different for people the same age in different countries. As you get older, again, I mostly study aging populations. The limiting factor is the ability to sleep. It's not really sort of what's going on in your life. So, I think there's a perception, and in the 1980s world and 90s, we heard a lot, and contemporaneously too, from like world leaders, from Margaret Thatcher and from Bill Clinton, that they only slept 4 hours a night. And that contributed to this idea that people were like not prioritizing sleep because their time was worth so much. But I really don't see evidence of that at a population level, even though there may be individuals. So I think the differences are not as great as we think across countries. This really is a physiologic measure. But you can prove it wrong. Go do a literature search.
Thank you very much for presenting today, Diane. We really appreciate it. Really fascinating talk. Jean, thank you for fielding questions and being here as well. And thank you everyone for watching. And please go to the CHAZ website if you wish to subscribe to our e-news and find out about upcoming presentations next quarter. Thank you.
Thanks, Diane.
Take care, everyone. Be safe.
Bye-bye.